And then once you are eligible to collect, and I'm not even sure that the statute defines exactly what the eligibility triggers are. It might be something like impairment in 1 or 2 activities of daily living at one level of benefit, and maybe 2 or more for a higher level of benefit. And the level of benefit is something like $50 or $75 a day. Not a big benefit. High premium, 5 years, not a big benefit. But let's talk about where there's an opportunity here. And the opportunity here is to start people thinking along the lines of a seamless, community of long-term services and supports. In past years, we, within SEIU, have tried to get the state to open up IHSS so that people above the IHSS income eligibility levels could actually buy into the service. Why not make this a service that everyone could have access to? A program like this with a modest benefit is a way to start doing that. It's one component of that. So it's not going to take effect right away. It is not going to solve next year's budget fight, but I just encourage you to think about it as something that maybe we could all partner on to look for ways to use it. Just as I said last year when we started working on this provider fee, it was a crazy idea, but we managed to actually turn it into legislation that passed. So that's what's going on with the Class Act. And then the other thing that I wanted to mention that I think is much more urgent, and it's really something we need to be thinking about as we move forward this year, and that's called Community First Choice Option, CFCO. Community First Choice Option is a new program that is open to people who have eligibility for nursing home care, but who want to stay in their homes. It is open to people who have incomes at 150% of poverty level or less. And what it does is it provides, in addition to home care support like IHSS, it provides other kinds of transitional services. It could mean rental assistance. It could mean it could mean repair services. It could mean other things not yet fully defined that a person might need to stay in their own home. And here's the thing about it. The money is supposed to start flowing from the federal government in October 2011. That's a year from now. The state budget, our fiscal year, is July 1st. And if it's anything next year like it was this year, we won't enact a budget until sometime in October. So that'll work out just fine, actually. But my point is that this is money, and it's a 6% bump in our Medicaid reimbursement rate. This is money that we absolutely, positively must access next year, because we will be under siege again. We will be threatened with massive cuts for next year. And this is a stream of funding that doesn't have an ending date, and it's imperative that we go after it. And I don't know about any of you, SEIU has inquired about this at the state level, and we've been told by the state that the message from the federal government right now is don't call us, we'll call you. So we got a problem here. So we will be spending a lot of time in the coming months figuring out how it is we can be creative to take what is probably a subset of the existing IHSS population, not take them out of IHSS, just get them categorized in such a way that they trigger that funding. And when I say a subset, I mean people who are considered eligible for nursing home level of care, which depending on who you ask could mean everybody or somewhat less than everybody. But we absolutely must figure out a way to do that. We need to get that extra money, and we need to fight hard to keep protecting our funding. And I think that the public authorities can play an incredibly important role to do this, because if you don't, others will, particularly people in the private sector who might have a motive other than protecting the program. And we work with private sector agencies. I don't want to say that that's a bad thing, But I think it would be much better if public authorities which are committed to consumer-directed care are at the forefront of this. So that's where I'll stop and let Rick take over.
Well, yeah, we've just gone through a very, very tough time in California. Over the 30 years, I've seen up cycles and down cycles in budgets. But California has gone through a sustained multi-year financial down cycle. And ironically, when the state gets pushed, it pushes back on all the things that it does well. Home and community-based services is one of those things that California has done pretty well over the years. And I think we need to be able to recognize, first and foremost, what has really been accomplished. If we look at institutional rates, how many people who are older or with disabilities in a population, and what percentage of those people are residing in institutions? Nationally, the average is 4.5%. In some states, it's as high as 9.5%. In California, that percentage is 2.7%. One of the lowest, and the lowest of the big states in the country. It's been doing something right for the past 30 years. Whether it was adult day services, in-home services, public authorities, home and community-based waivers, the state has gone a long way in improving services to help people stay in the community. Ironically, in the last few years, when the money's got tight, the people in political power don't appreciate what they accomplished. And they really fought to try to cut back on that. Ironically, if we did cut back on these programs, a portion, not everybody, a lot of people would choose to stay and die at home than go into a nursing home, but a growing portion would go into institutions and the cost would be significantly higher. Why didn't we communicate that message? Why didn't we get support for some of these changes? I think we have to recognize that today we are in a crisis, and there's a lot of changes politically with the election coming, and there's going to be a lot of opportunity to reshape things. In California, which has been so successful in building up home and community-based services, the state itself has had essentially an attack on those services. Ironically, nationally, the federal government is saying, let's do more of what California did. California IHSS program is the biggest personal assistance program in the country, serving over 400,000 people, providing with $4 billion in services, and providing jobs to over 400,000 workers, many of whom would not have jobs or would not have been paid or would not have health benefits as they do today. So that's a lot of accomplishment, and we need to be able to recognize that and build from that. In other places around the country, they started creating innovative programs, cash and counseling. Let's see if we can get somebody to give them the cash to be able to hire a home care worker and not go to a nursing home. Well, California's been doing that for 20, 30 years. So in some ways, we've done a lot. But it's time for us to also review and evaluate and see what we've done well and what we can do better. I think today we are presented, like in any crisis, where there's threat, there's also significant opportunity. The federal government today, as Deborah has pointed out, has brought up in the Affordable Care Act, the new health care legislation, created a lot of new initiatives that present opportunities to further the development of home and community-based services. I think it's imperative on all of us to be aware of some of these programs, to identify which of those programs make sense for us and our communities, and to become really focal points to advocate and bring about those change. I'd like to today talk a little bit about some of those programs, how they might address some of the needs that we see in ourselves and in our communities, and to help you identify what makes sense. Ultimately, I think we need the consumers to get behind the ideas that make sense and help define what makes sense. and to help in the implementation of these efforts. First of all, first question I ask, is California's IHSS program really enough? You know, it is the largest personal assistance service program, but it was developed really 30 years ago and reestablished, re-identified in the early 90s as a Medicaid benefit and reestablished again with some waivers in the 2000s. But it is a program that primarily focuses on personal assistance services itself, giving people the help of an individual caregiver to help them stay in the community. The newer piece of legislation recognizes that person help is part of the solution, but not the whole solution. And some of the new pieces of legislation that are out there are saying, hey, let's broaden what you can do with those funds. And that's where Cash and Constantly came into play, and that's where the programs now, where you're looking at community first choice programs, are essentially new initiatives in the federal government which says the states can provide the funding to provide in-home services and help and other kinds of services to help people stay in the community. Now, this is a program that, in effect, is very similar to what IHSS does. It does focus it only on the people who are nursing home eligible, but we found from our data that the majority of people are. And I think what it does is there's a corresponding legislation that allows it to expand it beyond that group to serve people who are at risk of institutional placement because of disability and impairment. We can look to these these programs, and incorporate those into the state plan to help make a broader array of services available. It might be help in getting home modifications done. It might be help in transitioning to better housing. These are things that can be supported under this new initiative. What's nice about the new initiative is that, as Deborah's mentioned, it provides the state 6% more federal participation. That means the federal government will pay a bigger portion of the total cost if the state doesn't. The challenge, though, is will the state choose to do it? As mentioned, it's going to be possible October 1, 2011, a year from now. But it doesn't require any state to do that. The state has to make the decision to do that. And they'll crunch some numbers, but they'll also be taking input from communities and people to see, is this something that they want? And then if it is, how do they make it happen? And that's going to be where the important features come into play, and where it's going to be very important to be involved in, is the implementation.
Rick, can I interrupt and ask, you mentioned the state plan, and first choice, would that, in order to enact it or implement it, is it part of the state plan? It becomes part of the state plan?
It would be.
Okay, for people just quickly, because this is where some of the technicalities come in. When California decides to participate in Medicaid or Medi-Cal here, it has to outline to the federal government how it's going to implement these federal monies and meet federal requirements and so on. And that is in a state plan amendment. You hear differences thrown around of whether it's a regular Medi-Cal program, an optional program, or a waiver program. I mean, Deborah Doctor kind of got into that in the session on the 1115 waiver this morning. The state plan amendment means that it becomes, until the state plan is changed, a permanent part of how Medicaid, Medi-Cal gets delivered in California, rather than these other programs that are optional and can sometimes feel more at risk, or a waiver program that is usually more targeted to smaller groups. So I think what both Deb and Rick have been saying is that if we push and are able to get something in the state plan, it becomes much more of a broad-based, permanent program and way to pull in federal funding for these services. Is that fair?
Very good, very well put. And I think the federal participation concept is important too. Right now, the federal government will pay 62% of every dollar that goes for IHSS.